Hello friends and welcome back to my channel. Now we are going to start the surgery because all of you are most probably done with the croc and you already received good marks. All of you has passed it. So I'm so happy that all of you has cracked the croc exam. So we will start with surgery now. I'm going to help you with the abdominal surgery portion. So I will provide you my notes as well, and we are going to study a bit deeper about surgery because it will be helpful with your next exams like FMGE and any another higher level of exams. So what we are going to learn in surgery is we will start with some actually the anatomy is really important to understand. So which anatomy we are going to talk about in surgery? We will be talking about the surgical anatomy. Remember, this is not the anatomical video. So we will be talking about the surgical part and the surgical anatomy, because you might have forgot it already. You learned anatomy in first year probably. So I'll try to recap you the best way, and we will start with esophagus. So first of all, do not get panic that we just finished talk, we need to sit for some time, we need to relax for some days. Actually, I'll tell you one honest thing, that students should never sit freely. If students will sit free, their mental capacity decreases. So try to cover just one video per day with me. We are not going to be very fast, but just try on 2x speed or 1.5x. I'm going to cover in shorter videos only. So just try your best, and let's start with the esophagus. We are going to cover the abdominal surgery or the GI surgery, starting from the esophagus to the rectum or anus. So I'm going to cover everything in details. There will be higher level of details, including TNM staging and what part to cut, including metastasis, everything. So let's start with esophagus, and tell me in the comments how do you like this surgery video, because I need feedback from you. If there is something, we can change the way of studying, So just let me know. I'm going to cover everything. This is a trailer video, introduction for surgery. So let's start. So first we are going to see our beautiful esophagus anatomy. Here is a beautiful diagram of our esophagus. So the main thing which you should remember is esophagus have three regions. One is cervical region, then there will be a thorax region, and then there will be an abdominal region. So the three regions, upper part is in the neck, which is also known as cervical esophagus. The thorax, the middle part, which is the longest part. Yeah, you can see the diagram which mentioned on the right side, and there is an abdominal esophagus. So let's look at it. There is you see the cricopharyngeal sphincter. This is located at the neck portion or the cervical portion. So this is a muscular portion which will be helpful in swallowing and a lot more things. But the lower esophageal sphincter, as you can see, is a physiological sphincter. Yeah, you know about the name lower esophageal sphincter. So lower esophageal sphincter is not muscular, it's physiological sphincter that you cannot control it. You can control the cricopharyngeal sphincter because that's muscular. So main thing about this is there is three parts: cervical, thorax, and abdominal. So also there are some three narrowing as well. So esophagus, our esophagus, we used to measure it from the cricopharyngeal sphincter, that the esophageal marking starts from here. So there are three narrowing. Why I am telling you this, that there are some three narrowing. For example, some foreign body got stuck somewhere. So when you will do the endoscopy or upper GI endoscopy, so you will be able to find the foreign body in three narrowings. So first narrowing is 15 centimeter, which is from the upper incisor cricopharynx. Actually, this is not hard to remember. Let me tell you a short mnemonic, that 25 plus 15 is equal to 40. This is how you can remember it a little bit. Remember the mnemonic. First narrowing is at the 15 centimeter, and second narrowing is at the 25 centimeter, which is the indentation of the aorta. Here you can see the indentation of the aorta, which simply means that aorta is going from the front part or from the anterior part to the posterior part. The aorta is going like this, something like this. So I hope you will remember this, don't worry. So third narrowing is some 40 centimeter from the cricopharynx. Remember, we are going to measure all of the narrowings from the cricopharyngeal sphincter, which is a muscular sphincter and also known as upper sphincter of the esophageal. So 40 centimeter, this is the diaphragmatic crura. So diaphragmatic crura, here you are going to find it. I'm going to explain you, don't worry. So I hope you will remember this rule: 15 plus 25 is equal to 40. So this is how you are going to remember it. This we have seen, right? Upper esophageal sphincter is cricopharyngeal sphincter, which is muscular, and lower esophageal sphincter is physiological sphincter. Let's go next. Next is blood supply and lymphatic drainage. First of all, I want you to remember one thing. When we are talking about the lymphatic drainage, so let's focus over the lymphatic drainage a little bit. So this is the rule in all over the surgery videos. We are going to see that the first station will be always on the surface of the organ, or let's say for example, we are studying esophageal surgery now. So first station of the lymphatic drainage will be always on the surface of the organ, right? Understood. So second station will be along the blood vessels supplying the organ. All right. And third station will be where the artery actually originates, or let's say a root of the vessel. So this is the basic rule which we are going to study in lymphatic drainage of all over the GI tract. So just remember, in first video the other parts are going to get easy for you. I am also going to upload this mnemonic or rule in the post section of our YouTube channel. And let's see about our blood supply. So blood supply, first of all, there are three parts, yeah: upper part, middle part, and lower part. Middle part is longest part, yeah. So upper part of the esophagus received blood supply from the inferior thyroid artery. How you are going to remember is, sir, upper part of the esophagus is present near the thyroid gland. So we are going to remember it that this is going to be supplied by the inferior thyroid artery. Yeah, you can see in the diagram, in the upper portion, upper part is supplied by the inferior thyroid artery. Let's see the second part, the middle part. As we know that in the middle part, is in the thoracic cavity, yeah. So there will be a descending thoracic aorta which will give the direct branches to it, and bronchial artery branches will be there. So let's see, in the middle part there is you can remember well with the diagram as well. So descending thoracic aorta and bronchial artery will be there. And let's see the lower part. So lower part is near to the stomach. How you can remember is gastric artery, yeah. It's near to the gastric portion, yeah. So celiac trunk, and some portion is also supplied by the lateral branches of the abdominal aorta, inferior phrenic artery. So let's see together the lymphatic supply as well as the blood supply. So upper part of the esophagus is supplied by inferior thyroid artery, middle part is supplied by descending thoracic aorta and bronchial artery, and lower part is supplied by the left gastric artery and inferior phrenic artery. Try to remember with the colors, because I tried to make best notes for you. I hope they will be helpful for you. If something is not clear, I'll spell it for you. And let's see the stations now. So as we all know that primary station or first station is going to be where is, sir, it should be on the surface of organ, yeah. So where is the first station? So here it is. You can see the red color. So first station is along, or let's say on the esophagus, directly on the esophagus. Why we are studying about lymphatic drainage? Because if you know the anatomy first of all, so you will come to know the blood supply very well. And if you know the blood supply, so lymphatic stations will also move along or side by side to the blood supply, yeah. So if there is some metastasis, we will come to know which portion we need to cut exactly. So if we know that there is some portion having metastasis, with the help of blood supply, we can understand or suspect the metastasis, that this portion might have got metastasis. It's better to cut this and this station for the lymphatic drainage. Hope I am clear at my point. So first station is on the esophagus, as we know that it should be where on the organ, and second station should be where along the blood vessels. So sir, here is our blood vessels, and you can see the second station, that the pink color highlights that this is descending aorta or aorta. So second station should be along the blood vessel which is supplying to the esophagus, right? And third station should be where? Third station should be where is the root of the blood vessel. So root of the blood vessel is where? Root of the blood vessel is near to the, at the root of a para-aortic also we call it. So here you can see this color, something neon color, it is written here that third station at the root para-aortic. So you have written it here as well. I hope my notes are good printed way. So here you can see that this is the aorta with the pink color, and this descending portion, the neon portion, is the third station for our lymphatic drainage. So let's remember it together that blood supply and lymphatic drainage, upper part of the esophagus receives from thyroid artery, middle part from descending thoracic aorta and bronchial artery branches, lower part from the left gastric artery and some lateral branches of the abdominal aorta. And lymphatic drainage, first station should be on the organ, which is esophagus here. Second station should be along the blood vessels, which is inferior thyroid artery, branches of thoracic aorta and left gastric artery, mainly we are talking about. So third station should be at the root or origin of the vessels, and let's say para-aortic nodes in the thorax. So let's go next. I hope this is clear now. So if we see that actually our body doesn't have just a lower esophageal sphincter in order to prevent your gastric juice or acid flow or backflow. Actually there are some 6, I can tell you right now, some 6 things which helps you prevent the GERD or acid reflux. So first is, as you know that our lower esophageal sphincter have some pressure, some resting pressure is there already, that it is pressured up, which prevents automatically the reflex of the gastric acid flow. So this lower esophageal sphincter have some narrowing space or some pressure which is 10 to 25 mm of Hg at resting pressure, and this pressure stays all the time with it, that it will not let the gastric acid comes or let the backflow, right? So it will keep the esophagus closed. However, our upper sphincter of the esophagus has nothing like some resting pressure or nothing like that, because you can control it by yourself. However, the lower esophageal sphincter is involuntary or physiologic. Also, as you can see this neon color, I have drawn it here. So the pinch cork effect of diaphragmatic crura. So you all know that there is the esophagus will pass through the diaphragmatic opening, yeah, or we also say the diaphragmatic crura. So when the esophagus passes through the diaphragmatic crura, it also gives it something like a pinching effect, you know, understand pinching? It will help it to stay narrow, yeah, and anything else will be abnormal, so we need to treat that. So pinching cord, where the esophagus passes the diaphragm has pinching effect on the lower esophagus. Okay, that's okay. And another thing is, third point, intra-abdominal length of the esophagus is, so there the esophagus is a long tube, yeah, we will talk about the length. There is some portion which is in the thoracic cavity, there is some portion which is indulged in the abdominal cavity, yeah. Under diaphragm will be started the abdominal cavity, and upper diaphragm will be the thoracic portion. So intra-abdominal length of esophagus is 1 to 3 centimeter. This is also helpful in preventing the reflux. And there are some rosette shaped muscular fibers at the GE junction. Which is the GE junction here? This is the GE junction. So there are some muscular fibers which also prevents the acid reflux. And I myself thought that the esophagus goes straight and stomach comes under the esophagus, but we all might be wrong about that. Actually esophagus is making some angle of his with the stomach, so this is not below the esophagus. Remember that upper portion of the stomach is making some angle with the esophagus, which is known as angle of His. Angle of His is what? Angle between the lower esophagus and the fundus of the stomach. And next point is phrenico-esophageal ligament. So it hitches the esophagus to the diaphragm, which is also helpful. So overall length of the lower esophageal sphincter is how much? Remember, anything from these things can be a question in exam. Yeah, that's why we are focusing over deep studies. So the total length of lower esophageal sphincter is considered some 4 to 5 centimeter. Remember, you can measure right now with your fingers that how much should be some 4 to 5 centimeters, so that you will remember it exactly. And intra-abdominal length is considered some 1 to 2 centimeter. So this is what we are talking about, that under the diaphragm, this is the lower esophageal sphincter. Which portion? The intra-abdominal portion. And this will be how much? This will be some 1 to 2 centimeter, and rest will be indulged above the diaphragm, which will be in the thoracic cavity. Let's go next. Next is development of the gut tube. So I will not prefer talking about a lot. Just remember about the main points here. And rest of the portions we will try to cover in another videos. Just remember the main thing, that when the embryo is getting developed, you all know that there is a ectoderm, there is a mesoderm, and there is a endoderm. So the intestine, or let's say the gut tube, or the abdominal tube, or gut tube, this is developed from the endoderm. So endoderm, here is the part showing of endoderm. So outer will be ectoderm, middle will be mesoderm. So what we are seeing right now is endoderm. So our intestine in the embryo get develops from the endoderm. So this upper portion is head, middle portion is longer, and the rest portion is the tail. So do not need to see a lot of things in this. We will talk about the development of the gut tube or other organs as well in detail. But just remember that development of the gut tube occurs from the endoderm. Endoderm lines the tube, which with the fold at the head end and fold at the tail end. So upper part will form the proximal part, and rest part will form the distal part. Head end forms the foregut, central part forms the midgut, which is the largest part. Yeah, as we can see here, the head part, which is this is head. So head part is there, and this is middle part, yeah, the red one, and this is the tail part. Don't worry if the diagram is not very clear or good to you. I'll try to give you some photo from Google as well. I'll collect everything for you, don't worry, including the x-rays as well. So the main thing to remember here is that our foregut, and let's come to the point directly, why too. So foregut, first of all, let's see what are the parts included there. So just feel with me, or imagine with me, the esophagus, stomach, and some part of the duodenum will be in the foregut. Okay, we are going in the series wise. You can imagine and feel it with me in your own body. So esophagus, stomach, and this is written D1. Okay, D1 or D2, howsoever you want to call it. Probably D1. I would have wrote it wrong. So esophagus, stomach, and D1, some part of the duodenum, is the foregut, and the rest of the part, midgut, starts from rest of the distal part, duodenum, jejunum, ileum, cecum, ascending colon, and some 2/3 part of the transverse colon is covered under the midgut. And hindgut, rest part left whatever will be in the hindgut, which is descending colon, or let's say the rest part of the colon, sigmoid colon, rectum, or anus, you can say, which anus is just the opening though. And you can find it here as well, esophagus, stomach. If this seems easier for you, so foregut will be esophagus, stomach, duodenum, some part of duodenum, all right. Then will be rest part of duodenum, jejunum, ileum, cecum, ascending colon, some part of the transverse colon, and rest everything will be covered in the hindgut. So let's see the blood supply as well of these guts. Don't worry, it will be easy, nothing is difficult in this portion. So foregut is supplied by the celiac trunk artery of celiac trunk, and arteries will get easier for you as more as we get to the other parts. In the beginning it may look a little bit difficult, but don't worry, by the end of the abdominal portion you will be able to remember and think about all the arteries. So just remember that midgut midgut is supplied by the superior mesenteric artery, and hindgut is supplied by the inferior mesenteric artery, and they are the branches of aorta. So try to remember it like this, that foregut is by the celiac trunk artery, midgut is by the superior mesenteric artery, in hindgut by the inferior mesenteric artery. And what are the anomalies which can be associated with the development of the gut tube? So here is the mnemonic for you, that vectoral disease or vectoral anomalies, or some people also say vectoral malformations. So these are the possible formations or malformations which can happen with the development of gut tube. If the gut doesn't develop, probably this is the gut, and a lot of organs, as you can see, covers in the abdominal portion or the gut portion. So if there is any problem in the newborn, in our newborn, so this is the mnemonic vectoral. So V highlights vertebral anomalies here, A highlights anorectal or the rectal malformations, and C part of vectoral states cardiac, sometimes the septal defects, and T for TE fistula, Tracheo-esophageal Fistula, which we are going to study now, and renal agenesis, R for renal agenesis, L for the limb abnormalities. Try to remember the mnemonic from here itself. However, I'll give you some good photo as well to remember if you don't like my notes. So first of all, we are going to talk about the Tracheo-esophageal fistula, because it should be covered in the abdominal portion. So what is congenital Tracheo-esophageal fistula? Fistula is abnormal communication between the tubular structures between like trachea and esophagus. So let's see how it occurs is, so when there is the course of development, actually this is how the trachea and esophagus gets to separate. Actually there is a septum formation between the trachea and esophagus. So the upper half of the foregut is divided into anterior and posterior parts. So anterior will be trachea and posterior will be esophagus. You can feel it with me, just try to imagine it in your own body, that in front there is, or in anterior portion in your chest cavity, there is trachea, in the posterior portion there is esophagus, so, and there is a septum between them, if the septum is not formed, this is known as some connection known as Tracheo-esophageal fistula. And this is what defect in the formation of septum of the upper foregut will lead to the formation of Tracheo-esophageal fistula. I hope I'm clear at my points. So next we will see the types of fistula. So there are some type A, B, C, D, E. So 5 types of Tracheo-esophageal fistula, and let's try to see them one by one. I tried to create a good diagram for you. However, I'll give you some image which will be more easy for you, stating 5 types. Just understand right now, try to understand the things. Tracheo-esophageal fistula type A. In the type A, there is no fistula actually. We classified it into the Tracheo-esophageal fistula, but actually there is no fistula in type A. So the upper edge of the esophagus is blind. What does it mean, sir? What is this blindness? Blindness simply means that the upper edge is not connected to anywhere. This is blind totally. So, and the lower edge of the esophagus is also blind, which is also not connected somewhere. And what you will see in the type A and type B as well is, type A and type B are a little bit similar, and type C, D, E are a little bit differently similar. So in type A and type B, the gap between the upper esophageal blind end and the lower esophageal blind end is literally too much that you will need some conduit to adjust it. So I'll tell you about this, how you can treat it, but let's see what to do. There is no communication between the trachea and esophagus in type A, and blind stomach as well, big gap between the esophagus and stomach, that you are going to need some conduit or some another part or some portion which will help you to connect both of the portion. Let's see the type B. In type B, there is only the upper has fistula. Only the upper esophagus got the fistula, and a lower esophageal end is blind, which is not connected anywhere. So this is also a big problem, and both what is written here, both type A and type B have long gap between the proximal and distal segment of esophagus. So how you are going to treat the patient? Sir, we are going to use the esophagus conduit for type 1 and type 2, or let's say type A and type B, because there is a big gap which is hard to join. All right, let's move to the type C, D and E. Actually, in type C, D and E, remember one point, that you are going to see gas in type C, D and E. So this is a good differentiation of the point, that in type A and type B there is no connection of the stomach portion with the lungs or trachea, let's say. So there is no air over there. But let's see, type C is the commonest type, which you are going to see in 85% of the patients, depending on country to country as well. But let's say this is most common in every country. That what happens is, in type C is upper esophagus end is blind. This diagram states that upper esophagus end is not connected to anywhere. Okay, I made it a bit wronger way, but I tried to cover with the red marker. Upper esophagus is blind. This is atresia, yeah. There is it was never formed itself, yeah. And lower esophageal has fistula with the trachea. So if the lower esophagus has fistula with the trachea, so from trachea to the stomach the air can pass easily, and this is why we are going to see this gas. So if you are gonna perform the x-ray, you will be able to see this gas on in the patient, no problem at all. And let's see the type D now. Remember that type C is most common type. So if you sometimes cannot suspect what is there, suspect type C, because we already know that this is more common. So if we cannot make some conclusion, so try to suspect C first. And in type D, what happens is, both the esophagus, upper as well as lower, has a fistula with the trachea separately. So this is also going to pass some air to the stomach, which you can see over the x-ray. Clear? Let's see the type E. So type E is H-type configuration. As you can see in the image, I tried to highlight it with the red color. So in type E, there is H-type configuration between the upper as well as the lower esophagus. So let's try to recap a little bit, that type C, D and E are easier to reconstruct. Sir, why? Because there is no longer gap between. You just need to correct the things like this, that this in type D, that you are just going to separate it a little bit from the trachea. That will be enough, yeah. In this one, you don't need too much conduit as well, yeah. You can see the gap in type A and B is more, so that's why you need a conduit in that. Most common type is C, and type A and B require some esophageal conduit to fill the gap. Yeah, I hope this is clear now. I'll give you the photo as well, don't worry. A photo which will make it easier for you to remember 5 types of the fistula. Age of presentation. So what, for example, most of the time it is congenital itself, yeah. We cannot live with the tracheo-esophageal fistula even one day, as you all are aware about it. So at birth, when mother will try to feed the child will start choking, because there is something abnormal between the trachea and esophagus, or let's say the esophagus was never formed, yeah. And the child can also die from aspiration. This is pneumonia. I might have written wrongly. This is pneumonia, the aspiration pneumonia. Sir, why aspiration pneumonia? Because maybe the child aspirate the mother's breastfeed milk if there is a fistula present with the trachea and the esophagus, yeah. So this is most dangerous complication, because our newborn has very small lungs. There is already very small surface area for the gaseous exchange in our newborn. So if there is a aspiration pneumonia as well, the complication is most dangerous considered here. How to investigate it? If you have option, try to go for CT already. If you suspect it, try to go with CT. But let's say we know that protocols will let us go for X-ray first, yeah. So what you are going to see on the X-ray, the feeding tube, you will try to insert a GI tube inside the infant, yeah. When we will be inserting, so if the esophagus upper end is blind, so it is going to get coiled, yeah. I'm gonna show you the X-ray in a minute. But just remember, just try to imagine that if we are going to insert a GI tube and the esophageal atresia is there, so imagine what will happen is the GI tube has to get coiled somewhere. Yeah, it will get returned, which will be very well seen on the X-ray itself. So you can suspect the esophageal atresia already like this. So what is written here? Infant feeding tube will not pass in the stomach because of coiling of the tube and can be seen on X-ray stuck in esophagus. Yeah, so and air in the stomach can be seen in type C, D and E. You are aware about it. And investigation of choice, let's say. There is a investigation method and there is always a choice. Like if you suspect for sure fistula, so you can go with the investigation of choice all the time. So most of the time we are going to do CT in our abdominal portion because we want to see the structures very well. Yeah, so remember it that most preferred is CCT of the thorax as well as the neck, so that we can identify the fistula if and also which type of fistula exactly. Yeah, CT will show you very well that where is the connection and how to treat it. Just reconstruct it as soon as possible after the birth, because our newborn will die without nutritions if they are not getting to the stomach of the newborn. So we will try to reconstruct it as soon as possible. This is gonna be an emergency type of surgery. And what we are going to do is we will just disconnect the fistula and reconstruct the esophagus in the type C, D and E. Remember, type C, D and E are a bit easy to reconstruct. So we are gonna easily just separate the trachea part and separate the esophagus part easily. And esophageal conduit we are going to need in the type A and B, because the gap is too much. So that's why we are going to use the esophagus conduit for the type A and B. And it can be our own body part as well. Maybe if I'm not sure about it, but maybe we can take some part from the colon as well. So because if it is helpful, we can go with the conduit or some another part. So I hope this is clear. So let's recap a little bit that type A there is no fistula. Type B there is only upper end or upper fistula. In type C we are going to see the only the lower fistula. In type D upper as well as lower fistula. In type E there is what? There is a H type of configuration. Yeah, as you can see, which is as the photos also say stenosis. So you can remember very well with this diagram. This is for you for making it easy. And let's see next is what? This is CT scan of what? CT scan of thorax cavity as well as the abdominal cavity. So you can see easily here that this is our sternum part and chest cavity, and this is our vertebrae part in the posterior part. So try to see over it that this is our tracheo-esophageal fistula, and this is how we are going to see it over the CT. So I hope CT will make it the best easiest to understand that which type of fistula exactly we have. Yeah, so CT is for this. And this is how, if the esophagus was never formed, or we call it esophageal atresia, this is how the GI tube is going to look over the X-ray, that it will get recoiled. Yeah, because it's not gonna pass below, or because there is no part of esophagus present there, it's atresia. So this is how the coiling is gonna look like. So this is it with this video. Please tell me in the comments or tell me personally that how do you like the video. I need the feedback from you, because we can make fluctuation in the way of studying, because this time we are going to study in the deeper knowledge. So if we need some fluctuations, we will make it accordingly. And this is short video, so you can cover with me itself. Yeah, it's not going to take a lot of time of your day. So we are going to cover abdominal surgery in shorter videos very well, no problem at all. And also please, one more thing, that after watching the video I will always try to throw a reel as soon as possible related to the video. Yeah, Please remember that after you finish the video, also go to the reel portion and also go to the post section. If there is something related to the video, I'll try to post all of the things, including video or any mnemonic or anything like more pictures related to the topic. You will find it in the reels portion. So please let me know in the comments how do you like the way of teaching in the deep surgical sessions, and you can ask me personally for the notes. I'll provide you with the notes as well. The best way of studying is, you know what, the best way of studying is you cover the video with me. Now you will see some photos in the reels with me, and if there is something related to the video which you cannot remember, or which we all forget easily, you can find it in the post section, yeah, so that we can recap it again and again. So the best way of studying is, after doing all this, just look at the notes one time by yourself so that they will get fit or scanned in your mind, yeah. And try to revise the things, because this is the mistake which I was also doing myself. And trust me, if you do not revise the things, this is gonna be tough for us to remember the things will be just charged in our subconscious brain for some time, and we are going to forget it somehow. However, we have opportunity to watch our videos again and again on 2x, no problem at all. But let's try our best and give the feedback. See you in the next video. Have a good evening.